Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Saxe Healthcare Communications, and I'm your technical producer. It is my pleasure to welcome you to today's webinar, Best Practices for Transitioning Patients from ICU to Step-Down Units, a Recent Study. And now, I'd like to introduce you to Dr. Ruben Restrepo, who is our moderator today. Dr. Restrepo is Professor and Coordinator of Research for the Division of Respiratory Care at the University of Texas Health Science Center at San Antonio, Texas. Trained in medicine in Medellin, Colombia, Dr. Restrepo went on to academic positions at Georgia State University and then at the University of Texas. He has published widely in the field of respiratory care, including book chapters and articles, and has given many presentations. He is a reviewer for several major journals in respiratory and pulmonary medicine, and is the recipient of many honors and awards for his teaching, publications, and volunteer work. Dr. Restrepo, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Absolutely. Thank you, Emily, for that very kind introduction. Good morning, I guess in the Americas. Good afternoon in anywhere you are in Europe or Asia. So the title of today's webinar is Best Practices for Transitioning Patients from ICU to Step-Down Unit, a Recent Study. And speaking today on this very timely topic is Dr. Sarah Hiley. Dr. Hiley has been in critical respiratory care practice for 14 years. Currently, she is the clinical chief specialist for the division of the Pulmonology Intermediate Respiratory Care Unit at the Fundación Jiménez Díaz Quirón Salud University Hospital in Madrid. A member of many professional organizations, including the Spanish Association of Pulmonology and Thoracic Surgery and the Society of Pulmonologists of Madrid, to name a couple. She has been awarded the Excellence in Medicine Education Award by the Spanish UAM University, as well as the Excellence Award for Clinical Management in Intermediate Respiratory Care Units. She has written 14 chapters, 25 articles, and is a regular reviewer for the Spanish Public Health Ministry and Archivos de Bronconeumonología journal. In regards to disclosures, our speaker has disclosed the following relevant financial relationships, as you see on the screen: grants research from Fisher & Paykel, advisory boards, Along Technologies and Fisher & Paykel, and consultant for Philips Respironics. I just want to remind you that this educational activity is approved for 1 contact hour for nurses and RTs, and you can see the accreditation statement below. And I want to thank Philips Healthcare for providing support for this educational activity. So now, it is a pleasure for me to introduce Dr. Sarah Hiley. So welcome to the presentation.
Hello, everyone. Thank you very much, Dr. Restrepo and Emily, for your introduction. I also like to thank everyone for joining this presentation and to Philips for supporting and organizing it. Okay, let's get started. I'm going to speak about the best practices for transitioning patients from ICU to step-down units. This is a recent study performed in my hospital in Madrid. Okay, for the current trends, growing utilization of non-invasive ventilation imposes increasingly complex needs outside the conventional ICU. There is an increased number of step-down units for monitoring and treating patients with severe respiratory diseases across Europe. The advantage of step-down units are that they require less resources than traditional ICUs. They can provide effective care for patients with acute and chronic respiratory failure and or those requiring prolonged mechanical ventilation outside the ICU and at a lower cost. They are actively present in many countries, and the correct use of SDU frees more beds for ICUs and avoids the provision of insufficient care to complex patients in conventional beds. What type of patients can we have? SDUs can be useful for a lot of patients, transitioning from ICU to the general or respiratory ward, those requiring nursing care or physiotherapy, those having difficulties in retrieval from invasive mechanical ventilation, patients requiring non-invasive ventilation or ventilation through tracheostomy, altered respiratory mechanics who require postoperative care, or life-threatening hemoptysis. About location and staff needs for S-DUS. They can be independently located for 25% and parallel to an ICU or integrated within an ICU or respiratory ward for the 59%. They are characterized by a lower nurse-patient ratio, often 1:4 as compared to ICUs, but requires constant presence of trained physicians. In the case of the USA, S-DUS has been present since the 1960s, and in the late 1980s, other units with lower levels of resources called non-invasive respiratory care units, intermediate respiratory care units or high dependency units. But despite some concerns in defining these units, the effectiveness has already been described but not quantified. There are experiences that suggest it is possible to provide effective care at a lower cost. In the case of Europe, we have had a rapid increase in number in recent years, and several circumstances have contributed to this. The first one is that the European Respiratory Society has shown a growing interest in managing patients with severe respiratory disease outside the ICU. Also, European ICU doctors are progressively open to the involvement of other specialists in the management of these patients. There has been a development of a joint consensus document, and there is greater importance on training in critical respiratory medicine. The rationale for S-DUS is that up to 40% of patients admitted to the ICU do not really require intubation. Only 40% of cases of acute respiratory failure require invasive mechanical ventilation, and up to 60% of invasive mechanical ventilation time is spent in weaning. So the question is management of resources available in the ICU adequate? To answer those questions, the aims of the current study, the primary aim is to describe effectiveness and efficiency of S-DUS in order to facilitate setting up of S-DUS in other hospitals. And the specific goals are to make a cost analysis in 2016 of our unit opened in 2007. We are going to analyze the total cost for the year 2016 versus the cost foreseen if patients were located in the ICU. We will check the most significant factors associated with cost that year, the 2016 mortality versus historical since S-DUS inception, and we are going to investigate the predictors of mortality in different ways. For that, we are going to make a closer look at mechanical ventilation in the ICU and S-DUS, talking about automated modes, the need of an increased number of patients requiring mechanical ventilation, prolonged mechanical ventilation implications, the levels of complexity, the new modes, ventilators, the modern ICUs and S-DUS. The population is aging, and this is a problem. The forecasts are that this situation will get worse. Every time there will be more people who need ventilatory support because the life expectancy also increases. Being true that the number of patients with ventilatory support does not stop increasing, it is also true that there is a stagnation in the number of doctors trained to manage this patient. This makes necessary the appearance of respirators and modes able of supplying the human being new automated modes and algorithms. From a management point of view, it is true that the economic impact of this increase in the number of ventilated patients implies a very significant increase in the cost of all the health system of the world. For the United States, for instance, in 2003, the cost of invasive mechanical ventilation was above 60 billion per year, 16, and the projected cost for 2020 is 60 billion per year. The expected increase in the number of patients who will need ventilatory support involve more complex mode, ability to self-adjust against asynchronous, algorithm capable of adapting to the patient mechanics and ultimately free the doctor. AutoTrack is a good example in acute patients. One of the problems of non-invasive ventilation are asynchronous, and AutoTrack as a mode practically eliminates them. In acute environments, the current automated systems are NAVA and AutoTrack. NAVA is invasive because it requires the placement of a probe and is frequently dysfunctional in the presence of leaks that are universal in non-invasive ventilation. AutoTrack lacks these problems. Our unit is an open room to guarantee the global supervision of the patients. This is necessary in the ratios that the SDU manages. My unit has chosen the AutoTrack algorithm for acute patient management due to its extraordinary ability to adapt to the frequent and unpredictable patient changes. Its compliance system and automatic migration to control mode have been the key to our choice. Now I'm going to speak about the direct benefits and savings. Our SDU infrastructure accounts with a material with 8 beds, 5 semi-critical beds and 2 cardiorespiratory monitoring, with 1 insulation bed with negative pressure and sleep monitoring. We have 11 respirators with 2 Servo-S, 1 Servo 300, 5 V60, 1 Vision, 2 Trilogy for transport of critical patient, 8 monitors with a wireless control. We are 2 staff, physician in the unit, and we have 3 doctors for weekend passes. There are not specialty guards, and in the absence of the staff, the unit is in charge of the ICU staff and general hospitalization doctors. We have 1 supervisor of nursing, and our ratio is 1:5. But in high-risk seasons, the SDU is extended to 8 beds with 2 nurses, and then we have the 1:4 ratio according to regulations. Other supplies are central scissors of oxygen, air, and heliox. We have a bronchoscope in the unit, gasometer, portable, ultrasound, everything for arterial catheterization of venous, central venous catheter, aspiration systems, infusion pumps, 5 per beds, televisions, earphones, high flow for everybody, percutaneous tracheostomy kit and cricotomy, manual defibrillator, an automated one, 4 computer stations, an own electrical box, and emergency in case of failure or of electrical system. Our current admission criteria are acute on chronic, on acute hypoxemic or hypercapnic respiratory failure requiring ventilatory support, exacerbation of chronic respiratory failure requiring non-invasive ventilation with or without hemodynamic support, need for sedation to adapt to non-invasive ventilation, serious uncontrolled obstructive sleep apnea, pulmonary thromboembolism with severe respiratory deterioration, severe acute respiratory failure in high-flow oxygen therapy, NIV or helmet, laryngospasm in post-extubation of resuscitation, weaning of complex patients of multidisciplinary origin, decannulation protected by tracheal ring in weaning, post-operative of risky thoracic surgery or post-operative acute respiratory failure, post-operative of any origin if it requires support of non-invasive ventilation, need for ventilatory support in respiratory failure of neuromuscular origin, cannulation with support of non-invasive ventilation, risk bronchoscopy, pneumonia of the immunosuppressed, and control of pulmonary hypertension. Our unit has progressively increased the number of admissions, and the failure rate remains stable at 6% since 2011. The results of our study for this year, 2016, are that we had 250 patients admitted with 1,390 days of stay. The average S-DUS DRG value was 3.59. The average stay was 5.62. The APR-DR32 level of severity was 3.44 and the mortality level 3.36. Those values are in the scale 1 to 4. Here I show the general characteristics of patients classified by diagnosis. Grouping by GRD of the patient's overall average stay and in the unit levels of disease, mortality, cost, and death in each GRD. Each episode is grouped into an APR with 4 possible levels of severity: moderate, minor, major, and extreme. Each of these levels has an increased weight value, expressions of resources consumption. That increases level from 1 to level 4. These weights are calculated annually in the United States. The levels of severity and probability of dying are automatically assigned to the 3M grouper according to the coding of the episodes. The greater the number of secondary diagnoses of complications of these patients, the grouper will signify the episode at a higher level of severity and probability of dying. The total cost of the SDU in 2016 annuity resulting from the sum of the categories described amounts to more or less 600,000 euros. For staff to calculate the personal cost, the entire existing workforce was taken into account in all work shifts. The salary cost corresponds to the current agreement in force. For consumption, we have access to complete information of the cost of all the sections that corresponds to this chapter and that were distributed in sanitary and consumer material, instruments, clothing, and other. For pharmacy, the consumption of pharmaceutical products was distributed according to their use measured in unit doses. For analytics and radiology, review of the medical records of the 250 patients admitted in 2016 was carried out, counting all the analytical profiles and all the radiological tests performed in that year. The direct costs are above 500,000 euros and the indirect ones in 100,000 euros. The estimated cost is if the patient was admitted to the ICU. We have in Spain 3 sections of complexity for ICU: low, medium, and high. Our unity is in the complex group 1. ICU saved costs associated with 1,390 ICU stays, so between 1 million and 1,100,000 euros per year. So the actual SDU versus ICU was 500,000 euros per year. Some direct benefits that comes from complexity in Spain and in the saved costs gives us a saving of 700,000 euros per year with this change. Now, I'm going to speak about the analysis of variables associated with cost. Relationship between weight, stay, disease, and mortality level with cost was statistically analyzed using linear regression models. First, the relationship between each variable and the costs was analyzed separately using multivariate models. Then, a global mortality multivariable model was obtained in order to see which of the variables have a stronger association with costs. The results are that costs were mainly associated with the average DRG value and mortality, so the complexity of the patient. This analysis confirmed that a highly complex SDU can reduce length of stays in the ICU and therefore greater cost savings. To analyze mortality, we take a cohort from 2004 to 2017, and we use univariate logistic regression model. The number of patients were more or less 2,000. And in table A, you can see the cutoff values for every variable according to the Juden G index. Table B show the results for univariate logistic regression analysis. This is the multivariate logistic regression model with the area under the curve, the sensitivity and specificity, and the ROC curve. The goodness of fit of the model was evaluated by the Hosmer and Lemeshow test, finding that variables that, when combined, best discriminated between classes were respiratory rate, number of leukocytes, value of hemoglobin, potassium level, and pH. The area under the curve was 0.75. An internal validation of the bootstrap indicated an optimism of 0.016, which reflects the robustness of the model. But to go on with mortality prediction in the S-DUS, we have made a novel use of artificial intelligence. In fact, we created a neuronal network for prediction and automated learning of our patients' mortality. The background for that is that S-DUS have traditionally used various scoring systems for predicting mortality that have been inherited from ICUs. It has been generally accepted that these models tend to lack sufficient calibration to be used on an individual level. Neuronal network produce a trained model, which can then be used for prediction purposes. The ability to predict the risk of mortality for ICU and S-DUS patients could really facilitate optimal allocation of staff and resources to high-risk patients and ensure timely interventions. For this study, data were confidentially collected from a total of 2,000 patients admitted to the Fundación Jiménez Díaz Quirón Salud Hospital, our hospital located in Madrid, from January 2007 to December 2017. The study variables were vital signs upon arrival at the hospital prior to being admitted to the ICU. These were respiratory rate, temperature, systolic and diastolic blood pressure. Others as hemoglobin, platelets, leukocytes, blood glucose, potassium, sodium, creatinine, partial oxygen and carbon dioxide pressure, pH, bicarbonates, and base excess. Also age and, of course, individual mortality or survival upon discharge from the SDU were recorded for each patient. In this table, you can see the global profile of the cohort included in the study with 10 years of study, 2,000 patients, with a mortality rate of 1.68% and a failure rate of 6%, as I mentioned yet earlier. The mean age was 75, and the 83% of our patients were on a non-invasive ventilation treatment, 2% in high-flow oxygen treatment, 15% of the patients were on weaning procedures, and 26% of our patients, our complex patients, were on vasoactive drugs. On your right, you have the table with a description of the variables and their values introduced in the analysis. The percentage of non-available values indicates the missing values of every variable, and this is very important to create a multi-layer perceptron of the neuronal network. And as you can see, we did not use ENR because the percentage of not available value was very high. We use to start principal component analysis, and we found no observable differences between patients' classifications according to mortality. And the problem with the neuronal network was that our data set has a very low mortality ratio, less than 2% in the complete historical series. As with any machine learning method, neuronal network is based on the capacity of learning the global properties of the classes given in the training data set in order to predict the classification of new events. Given the imbalanced class distribution of our cohorts, working with a whole data set introduces a strong bias towards the learning of futures that favor life over death. Despite an acceptable area under the curve, as you can see, and the extremely high accuracy value of 0.98, it displays a very low specificity, which reflects basically that classifying everything as alive guarantees a high percentage of success, but fails in the classification of the most critical patients. To correct this problem, to avoid the imbalanced class distribution bias, we introduced a resampled step where the dataset is downsampled to have the same number of dead and alive events. Figure A shows the neuronal network performance over a set of resampled matrices that have a balanced class distribution. Although the behavior of the model in terms of accuracy does not improve the performance, using the imbalanced dataset we observe an important increase in the area under the curve of 0.71 sensitivity and specificity values. The parameter selection in the prediction of patient death finally was for the classification using, of course, the balanced data strategy, shows that the most relevant parameters associated with mortality were thrombocytopenia, metabolic acidosis, anemia, tachypnea, age, sodium levels, hypoxemia, leukocytopenia, and hyperkaliemia. The combination of these parameters reflects potential respiratory failure associated with hypoxemia and secondary pancytopenia, or a primary oncohematologic disorder with associated septic respiratory distress. The neuronal network, the overall algorithm, in fact, can be scaled to any type of unit in the world, intensive or intermediate, offering personalized results adapted to the particular environment of the unit analyzed. As a conclusions, say that the S-DUS can prevent ICU admissions and reduce costs. They improve distribution of hospital resources. A high complexity S-DU reduces cost more significantly and provides a safe environment with low mortality rates despite the complexity of admitted patients. Development of a reliable risk stratification tool finally in the S-DU is feasible. The algorithm is able of identifying and classifying mortality predictors in the S-DU of a general hospital. When combined with multivariate regression analysis, it has provided us with an extremely useful tool for the real-time monitoring specific mortality risks. The overall algorithm can be scaled to any type of unit in the world, offering personalized results adapted to the particular environment of the unit analyzed. That concludes my presentation. Now, I would like to turn it over to Dr. Restrepo. I look forward to your questions. Thank you very much for your attention.
Dr. Hiley, there was a superb presentation and excellent pacing, so I think we will have plenty of time for questions. So let me actually, just before we do open for questions, I guess it was very clear based on outcomes. I'm going to make a comment that if I'm getting sicker, I know a place where I want to go with the success that we had. This is quite amazing. Let me remind everyone that this educational activity is approved for 1 contact hour, and only to obtain the CE credits you have to go to saxetexting.com/BO, and you will need to register at the site. Please complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. I want to thank again Philips for supporting this educational activity. So I want to just go ahead and just open this for questions. And again, my comment is that it is quite amazing just to see the implementation of step-down units. And I want to go ahead and start with question by Steve that mentions that, of course, Sarah, that the step-down unit failure rate is very low. So the question that he has, based on the fact that 83% of your patients are on non-invasive ventilation, and I think you reported an overall failure of 6%. So what is the failure rate on non-invasive ventilations? And the second part of the question is that if they do fail, are they moved back to the traditional ICU?
Okay, thank you. So it's real. The mortality we have is very low, and the big number of patients, the more important number of patients are on non-invasive ventilation. This mortality has been declining over the years as a result of specialization, new technologies, more precise ventilation algorithms, auto-track, and in general experience of the staff. However, it
So
seems that,
would you say,
yeah.
sorry, so would you say that the 6% failure rate that you reported, is that also related to non-invasive? So if you have 100 patients on non-invasive, about 6 of them will fail and go back to the ICU? Or what do you do with those patients who fail?
Yeah, the patients who fail on non-invasive ventilation or on
Mhm.
high flow goes to the ICU. Exactly.
Exactly.
This is
Okay,
exact. Yeah.
okay, perfect. Also, a question by Steve. He's asking if obesity was also a risk for higher cost. What was the relationship? Do you find any obesity related to any of those outcomes?
We didn't study the obesity as a variable, as
Hmm.
you can see in the presentation, and as an isolated value or variable. We did not introduce this in the analysis. We have not this
Is there?
data, the entry data.
Yeah, I'm just curious because I just went to Madrid a couple of times, but I didn't see a lot of obesity. But are there a lot of obese patients in Spain? Is that a significant issue?
No, no so much, no so much. We have this
That's what I
problem
thought.
in Spain, but the Mediterranean diet
Yeah,
is a good fat for us. So obesity
exactly.
is not our real problem.
That's what I thought. Okay, we have a question from Diana, and Sarah, she is asking, could we conclude that the automatic algorithms like AutoTrack have some effect over the length of stay in the step-down unit?
Absolutely. If you look at DRG, the complexity of our patients, it's a very high complexity here in Madrid. And the length of stay, the minimum was 6 days. Non-invasive ventilation has something to say about that. And in my case, I just can't speak about AutoTrack because it's the only algorithm I have used. And I have chosen this algorithm exactly what I have explained, because it is able to reduce asynchronous dramatically. If you see the asynchronous that can give you another kind of algorithm, the usual algorithm of pressure support, ventilation with triggers, etc., there are a lot of asynchronous, ineffective efforts, prolonged inspirations, and everything. But AutoTrack really, when you analyze this algorithm in branch or with the patients, there are two asynchronous that survive, only two. The prolonged inspiration and some ineffective efforts in the case of not compensating correctly the autopip, and that's it.
Mhm.
So there is a reduction, a very important reduction, and this is one part of the problem that has been solved with AutoTrack. The other part is the capacity to move from the AutoTrack, from the pressure support with the AutoTrack algorithm to the pressure control mode in an automatic manner. So
That's very
we are
impressive.
not, you do not need to have the physician at the bed of the patient changing modes.
Yeah. And I have a comment by Audrey that these are also very impressive outcomes, but also Audrey has a question. Uh, were were there any other variables altered within the last 10 years? So I think the question is more like, did this study is coming from a previous study? So how did you come about this study? Have you done a pilot before? So how did it come about?
How did we do the study?
Yeah, so was this
Yeah.
based on a previous experience that you
No,
were
no,
trying
no,
to
no.
implement something small, or a previous study that was already published that kind of just
No,
prompted you
no,
to
no, 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 no. This is right now submitted, okay, in the third revision. So we hope it would be published in the next month. But how we do, why we do this study? We had a big data Excel, okay, with a lot of entries from 2004, and we have a low mortality, but physicians always want to reduce this mortality, and we wanted to do that, but we are not able, seeing this Excel with big data, with 30,000 data, to see something inside. So we made statistical analysis, and we made two kinds of statistical analysis for that. It's real that we do primary multiple linear regression that already give us predictors of mortality, but in fact, we wanted to have more informations. Even if the results of both techniques offer similar predictors, the regression gives us the cutoff values of all the variables, something that the neuronal network does not do. But the latter is very powerful. On the one hand, you can continue to learn as we introduce patients over the years and may the future increase their accuracy and adapt to the changes that the unit undergoes. On the other hand, the algorithm that is offered is generic. That is, it can be applied in any unit. The neural network will offer the results of the mortality predictors of the unit that is analyzed. It will adapt to his history, to the gestures that are made in it, to the particularities of the patients admitted to them. It is globally scalable and adapts to different environments. Additionally, in this world right now, like today, where all the variables can be monitored, hospitals are digitalized, it is important. The dump of all this data is crucial information to continue learning and improving our institution.
Very good.
I don't know, I have answered.
Yes, absolutely. Sarah, I do have a question from Michelle asking, do you have a rapid response team or something similar in European hospitals?
Excuse me?
A rapid response team. When a patient has a cold or something, do you have a designated?
Yes, of course.
Okay.
Yes, of course. If everyone gets worse or everyone happens, of course, in Spain as in everywhere, we put everything on the go, and anesthesists at the ICU, cardiologist, everybody comes to help the patient, and we decide if he stays in the S-DUS or he goes to the intensive care unit. There is a protocol for that in the hospital, in every hospital in Spain.
Yeah, because she's asking if this has probably any significant impact on the failure numbers. So so having response teams have been proven, of course, to be associated with better outcomes. So she's just trying to see if you do have the rapid response team, this may actually help with your statistics as well.
Yes, perhaps. It's probably yes.
Okay. I do have a question of my own, and I guess, as I mentioned before, with this impressive outcomes, I know that if I want to get sick, I know that I'm going to go to your step-down unit. But on the other hand, I wanted to ask a question just based on a comment that was made also by Steve, is that, so it appears that you don't have a physician at the bedside at all times, or do you, and how is this possible?
If we have a physician all time
yes.
in the unit?
Yes.
Yes, of course. Yes, of course, yes. There are, as I said, 2 physicians from 9 in the morning to 18 in the afternoon, 6 o'clock here in Madrid in the afternoon. And after that, we have the ward, the physicians of the ward. We speak, we have a meeting with them at 6 o'clock p.m. in the afternoon, and then they stay in charge of the unit. For patients very critical, the staff of the ICU is helping this patient, monitoring this patient.
Okay, and you don't have respiratory therapists, is that right?
Yes, we have.
You have respiratory therapists, okay.
Yes, in the morning and in the afternoon, yeah.
Okay.
Physiotherapist.
Exactly, physiotherapists. Yeah, because many of the countries in Europe do not have respiratory therapy, but they have either nurses trained in respiratory respiratory care or the
In my
physiotherapy
unit,
that happens in South America, yes.
no, in my unit, and because part of my formation was in France, in Paris. I see that this is very, very important, and here in my unit we have this in the morning and in the evening. Yeah, it is very important for winning patients, for instance, too.
Exactly. Sarah, Audrey had a question if you can repeat the original mortality rate. So what was the original before the S-DU? So what was it before?
The mortality in 2004, I have here the data. If you give me 1 minute, what was about 10%. I can check the graph because I have this data. Where?
Okay.
Yeah, I have it.
But it came down.
Yeah,
It came down to about 2%. Is that right?
10%. 10% in 2004, and it has got stabilized in 2012 in 6%, and this is our actual ratio since 2011, 12. Yeah.
Okay. Yeah, this is coming from Ashley that says we have RTs here in my hospital. I think it varies. So if you go to different countries in Europe, there may be chances that some institutions will hire RTs traditionally trained from US, from Canada. And of course, you have maybe a few countries in Asia like China. You have also Taiwan that provide the training. So there are some more schools, more bachelor's degree respiratory care programs. But in the typical case, it's going to be nurses and physical therapists, as it happens in South America. So let's say, since you have the physical therapist, I have a question from Linda. And so what is the staff-patient ratio for the physical therapist, and if they are involved in the protocol with these patients? So you mentioned that you had a 1-to-5 nurses ratio. So what about physical therapists? Do they care of 10 patients? What is the ratio for the physical therapist? Okay, 1 to 2. So it's even better. So you have more physical therapists, in fact.
Yeah.
Okay. And they are actively involved in the protocol.
Sorry?
They are actively involved in the protocol for the SD.
Yes, they are. Yes, they are.
Okay. Okay. That's very good.
Yeah.
I wanted to ask you something, Sarah. So when physicians get trained in internal medicine, are they double certified? Do they get trained as pulmonary doctors in ICU, or they are two separate specialties?
You can repeat the question, Robin.
So if you finish internal medicine as a physician, if you want to specialize, you have to specialize in critical care or pulmonary medicine, or you can do both.
No, in Spain it's different. In Spain, you must choose pulmonology as a specialty. Okay, internal medicine is another one, and you cannot do like as in France or in South America, I think, but I'm not sure. In France, for instance, you do pulmonology for 4 years, and after that, if you want to do critical respiratory care, you must do 2 years more of super specialization, if you want. This is the name in France. In Spain, no. In Spain, you are a pulmonologist, and inside your training on pulmonary medicine, you spend 6 months to 1 year in the intermediate respiratory care.
Exactly. Yeah. Here in the U.S., it's very similar. I mean, most programs will actually separate, but here in UT Health Science Center, they are double certified. So they are both pulmonary, certified, board certified pulmonary doctors, and also ICU. But in many places in the U.S., you have to choose, as it happens in Spain as well.
In Spain, you must choose it because the two specialties coexist.
Yeah. Okay, perfect. Yeah. Tamika was actually just wondering the same thing about RTs because they are typically called for all of these scenarios. I wanted to ask a question about, so what do you think was the most significant obstacle in trying to get this going? Because I know this is not something that you do overnight. So in regards to the planning, when you were thinking about doing this, what was the most significant obstacle that you found?
To create an intermediate respiratory care unit or SDU?
Yes.
Well,
Yes.
I sincerely believe that an analysis like the one we presented today was necessary,
Mhm.
objective and without major areas of uncertainty. The problem is that this message must reach the managers. Our experience is excellent in terms of management, quality of care, and mortality outcomes. I believe that managers are always afraid to create something new. Not in
Mhm.
vain, we know that when beds are created or generated, patients are generated. But you should know that they must know that the economical effort derived from starting a unit such as the one we present will be amortized in the shortest time and will give benefits very quickly. In addition, and above all, it favors the patients in terms of comfort, quality of care, and reduced mortality, as I showed.
Mhm.
The problem is information, Robin.
Okay. Yeah. I wanted to just confirm because Bob was was asking to confirm if we said that they do not have respiratory therapists, so that is correct. So even though you may have respiratory therapists trained from outside, working in Spain, they typically do not have this, so they study physical therapy and they specialize in respiratory care, but not because they are respiratory therapists, but also physical therapists. And yes, the ratio is 1 to 2, so it's actually a better ratio than the one they have with nurses. I wanted to go back to Steve. Steve made a comment, and this is the question. So how do you use the results from the mortality prediction from the neural network in practice? So in reference to the network practice, the main question that Steve is asking is, do these patients get followed more closely than what you believe in the past?
I think yes. I can affirm yes. The results, we have yet these results. And
Okay.
in fact, what we have made an algorithm, okay, with these results. Um, then we have made a prospective cohort with 150 patients after we knew the results of the neuronal networks. And the algorithm application was that all patients that meet the criteria we presented to the ICU before as admissions to our unit. Okay, a total of 60 patients received this vigorous treatment.
Mm-hmm.
One of the patients did not recover after the intervention and was referred to the ICU surviving. We had another decision with hypoxemic patients. If in 1 hour they did not perform a good PO2, he would be referred to the ICU.
Mm-hmm.
For decision 2 was applied to 23 patients and no patient required transfer to the ICU, and there was no disease. And finally, 40 patients of the cohort were handled differently from how we previously did before knowing the results of the neuronal network. So in fact, during the period of implementation, we had 2 disease and a mortality rate of 1.33, so it has diminishes. And the previous, if you remember, the previous historical average being 1.68, which shows more than 20% of decrease of mortality.
Mm-hmm. So I'm going to be the devil's advocate here. So I'm going to just be I'm going to kind of just bring back news in regards to, let's say I am reading your paper now and it has excellent outcomes. And I want to pay close attention to your discussion saying, these are the limitations. This is what you have to keep in mind. But let me tell you where I'm coming from. If I review your data, I mean, it's exciting to see that the step-down units carry such great outcomes. I mean, who wouldn't want to implement something when you can reduce mortality to 2%, when you have a failure rate of 6%? The question is, when you do something like this, isn't that you're paying much more closer attention to the patient, and that has a lot to do with the outcomes? Again, I'm just being the devil's advocate, so.
I don't think so, because this is a retrospective analysis, Ruben. As I told you, we had an Excel of 10 years, and then with the inside these 10 years, we had this 6% of failure and this 2% of mortality, and we did not implement anything new apart experience, new algorithms, new respirators, and I think this is the key.
Mm-hmm.
Not another intervention. It's the history of the innovation inside the ICU has reduced historically mortality, as I show in the graph. It's
And the
now
reason,
with
yeah.
It's now with
mm-hmm.
sorry.
Keep going.
No, it's now with the results of the neuronal network that we implement changes. And now I can tell you, yes, we have reduced mortality because we have done something new, directed, prospective to the cohort. But not before it. Before it is a retrospective analysis.
Exactly. The reason why I want to make a comment for those either physical therapists, respiratory therapists, or nurses who take care of the respiratory therapy part is because it's been shown clearly that some of those auto-track or some automatic modes of ventilation do not work unless you train people to actually just be able to catch the moments where you need specific attention. If you only rely on the automatic modes, it hasn't been shown that it just improves outcomes. So I think it has to be, the clear message here is that even though the auto-tracking, artificial intelligence, whatever protocols or simulation you create, I think it requires special training to know and to recognize when the patient needs your attention just versus an automatic mode. And that's why the criticism has been is that untrained professionals cannot just simply rely on automatic modes thinking that this is the way for me to step away from the unit so the outcomes can improve.
No, absolutely. Yeah. Absolutely okay with you.
Anthony had a question in regards to, so even though you don't have specifically respiratory therapists, but you have physical therapists or respiratory physical therapists, do you have a protocol for them to wean the ventilator and make changes when necessary, or they are only ordered by physician?
They are ordered by physician.
Okay, so there's no protocol that allows, let's say, the physical therapist to make changes on the rate, tidal volume, peak pressure, and so forth.
No, the protocols.
Okay.
Yes. The protocols are of lots of things, but not in changing parameters of the ventilators. If something happens, for that we do that.
Okay.
We explain to them. They are with us, but we do that.
Okay. Yeah, that's a very important question, Anthony, because here in the U.S., when we have protocols, and I just wonder, Sarah, what the impact of something like this will be. When we have protocols here in the U.S., it allows, of course, the RTs to make changes as long as you stay within parameters. So, for example, you can tell the respiratory therapist by protocol, you have to keep saturations above so you don't have to wait for the physician's order to change the FiO2, so you can liberally, because you know your patient, to make those changes or make adjustments based on CO2. If your target CO2 is between, let's say, 45 and 55, well, you can be on standby, but otherwise you make adjustments. So the physicians can actually tell here the type of change that you want, but you don't have to be ordering that. I just wonder, how do you believe that this may make even a much more positive impact if you had these respiratory physical therapist protocols?
Our respiratory protocols made that they can change FiO2, okay?
Mm-hmm.
For SO2 objective, okay? But if we must change parameters, ramps, rise times or something because the patient deteriorates, the physicians do that. Okay. Right now in Madrid, the physicians do that. But for FiO2, I agree, they do that. They can do that.
That sounds good. There is one question by Carl, and we're just almost wrapping up. Is, do you use high flow? So the answer to this question, Carl, is that yes, they do use high flow nasal cannula. So it's massive use of non-invasive, but they just. So how often? I mean, just to remind us, Sarah, how often do you use high flow nasal cannula? So if you have 100 patients in the step-down unit, how many of them are typically on high flow?
What, every year, More. If you see the data of the 10 year of a study, it is surprising. Perhaps the 2% of patients were on high flow, because high flow is recent. It's not as invasive,
Yeah.
non-invasive ventilation. But today, in my unit today, every patient has non-invasive ventilation and high flow. You know that now the step down, the step down of non-invasive ventilation, the time we retrieve non-invasive ventilation to relax, to the patient to speak or to eat something, we do not want to do that with oxygen, with normal oxygen. We do that with high flow because of the benefits in that space, the benefits of a little PIP, and we do not depressurize thorax. And this is important for us. And for hypoxemic respiratory patients, of course, and since 2015, the New England Journal of Medicine tell us that high flow is better than non-invasive ventilation. So those patients are directly put on high flow.
Exactly. So let me just actually reinforce the question. So today, in your unit, if you have, let's say, 50 patients, how many of those are on high flow nasal cannula? What is the percent? So if before it was like 2% or rarely because it was relatively new, today, what is the split between non-invasive and high flow? What would you say the percents are? Non-invasive and high flow.
Today, in my unit, but mixed or only
Yes.
high flow and only non-invasive?
Only high
Because
flow
this is
and
important.
non-invasive. Yeah.
Only 50%, only 40 to 50%,
Okay.
but mixed,
Yeah, that's what I thought.
everybody.
That's what
Okay.
I thought. Okay, perfect. So let me just make it one comment because we are running out of time now. So Angel makes a comment that therapist-driven protocols are huge in my hospital. Many doctors entrust us with weaning patients off the ventilators. Is it normal for European countries not to employ therapist-driven protocols? I can answer that for you.
Yes.
Yes, it is very common not to use therapist-driven protocols. And I would say in Europe and many countries of South America, that's also the case. I think most of the therapist-driven protocols are here in the US and Canada, but in other parts of the world, the therapist-driven protocols are just limited to probably just oxygen weaning protocols, as Sarah just mentioned before. So sorry to say that we are just nearing the end. So I want to thank Sarah for, again, the excellent presentation. It was a pleasure to work with you on this webinar. Thank for those who are attending. So it is time to wrap it up. So let me just turn this over to Emily for concluding remarks. Thank you very much.
Thank you.
I'd like to thank you very much for your time, both Dr. Haile for this very informative presentation, and as well to you, Dr. Restrepo, for being our moderator today. It has been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.